Welcome to the EAU Podcast. In this episode, Update in the Management of Recurrent Urinary Tract Infection, we are joined by Professor Chris Harding, Professor Gernot Bonkat, Assistant Professor Kathrin Bausch, Dr. José Medina-Polo and Dr. Carolina Ochoa Vargas. Together, they will provide a practical update on the contemporary management of recurrent urinary tract infections. Join us as we embark on this informative journey.
So, good evening. Recurrent urinary tract infections are a heavy burden for millions of women worldwide, deeply affecting not only their daily lives, but also the quality of life. We will explore how to translate the latest evidence into practical strategies that provide patient relief while upholding antibiotic stewardship. As your host tonight, I'm delighted to co-chair this session with my friend Christopher Harding, well known for rehabilitating the use of methenamine in the setting of recurrent UTI through the landmark ALTAR trial. He will now introduce our three expert speakers. Chris, the floor is yours.
Thank you very much, Gernot. So welcome, everybody. I'd like to get straight down to business and introduce our first speaker, who is Dr. Kathrin Bausch. She's a urologist based in Basel in Switzerland at the University Hospital and is also a member of the EAU Infections Guideline panel. She's going to talk about phytotherapy in urinary tract infections. So over to you, Kathrin.
Hello, everybody. Today I'm going to talk about phytotherapy in the prevention and management of recurrent urinary tract infections. So urological infections have always been really popular and even caused some fashion trends, like the codpiece in the time of Henry VIII to cure and probably hide local symptoms of the syphilis, or the wigs during the time of the Sun King to hide the alopecia caused by syphilis. And urological infections remained really popular until Alexander Fleming discovered the penicillin beginning of last century. More and more antibiotics were then brought to the market, however, not in the last decades. And antibiotics seem to be an inseparable pair with resistances, and sometimes only short after antimicrobials are on the market, first resistances develop. And that is a growing threat. By 2050, there will be around 10 million deaths annually due to antimicrobial resistance, which is even more than cancer. And in this study, E. coli is the primary bacteria, and urinary tract infections are among the top 10 of localizations. So antimicrobial stewardship becomes more and more important. So what are measures of antimicrobial stewardship? Indication, do we actually have a bacterial infection that needs to be treated by antibiotics? We need non-antimicrobial alternatives. We need to minimize the focus, especially as urologists or surgeons. We need a reduction of duration and doses of antimicrobials, de-escalation. We need to choose the correct antibiotics. And of course, we need to generate evidence, we need guidelines. And today, I want to focus on the non-antimicrobial alternatives. And of course, also a bit on guidelines and generating evidence. With this pharmaceutical industry unlikely to deliver new antibiotics anytime soon, we are going back to our roots. Literally back into the woods to collect herbs, just like our great-great-great-grandparents did. But because herbal remedies are often viewed either as magic potion or as complete hocus pocus, the EAU took on the task of separating fact from fiction and bring some evidence-based clarity into that field. And in July 2024, a systematic review was performed on the role of nutraceuticals in managing cystitis. 995 abstracts were identified, 44 were selected for full text review, including 20 systematic reviews and 24 original publications. We found 9 trials on the management of acute cystitis and 16 that focused on the prevention of recurrent UTI. And those were the primary foci of the systematic review. To assess which nutraceuticals effectively relieve acute cystitis symptoms and to evaluate their availability to reduce recurrence in especially recurrent urinary tract infections. Don't worry, I'm not going to discuss all of these studies in detail because herbal medicine, phytotherapy, represents just one branch of the much larger nutraceutical landscape. So we will step right into the management of acute cystitis first with cranberries, which is not quite clear if it's a nutraceutical phytotherapy. But since it's kind of like from the woods or from a plant, I included it here. So there's evidence from 3 RCTs, including juice and capsules, on the management of acute cystitis, but they showed a very high variability in the active substances. And there's no clear evidence for the efficacy in acute cystitis, maybe also because the studies were not primarily designed for this outcome. Our first combinational treatment for the management of acute cystitis, the first plant is Centauri herba, which is century, and it's supposed to have an anti-inflammatory effect. It increases diuresis, decreases adhesion of bacteria, and has spasmolytic effect. Levistii radix, which is lovage root, also has anti-inflammatory effect, spasmolytic, it increases diuresis, and in vitro it shows an inhibition of bacteria. Combined with rosmarini folium, which is rosemary, that has an anti-inflammatory effect, analgesic, and it also decreases adhesion. These substances combined were investigated in a phase 3 double-blind parallel multicenter RCT, including 659 patients, and were compared to fosfomycin in patients with acute cystitis. The primary outcome was the avoidance of additional antibiotics, and the herbal combination could show or prove to be non-inferior to fosfomycin. 83% of patients receiving the herbal combination could avoid additional antibiotics compared to 89% in the fosfomycin group, and the non-inferiority margin was 15%. The follow-up lasted 38 days in this study. So the next combination consists of L-methionine, which is an essential amino acid acidifying the urine, which is the way of action for this substance. It's combined with Hibiscus zaptarifa, which is roselle, that is supposed to decrease adhesion, comparable a bit to cranberry, but it's significantly under-investigated compared to cranberry. And the third is Boswellia serrata, which is frankincense, that inhibits the pro-inflammatory leukotriene synthesis. This combination was investigated in RCT and was compared to short-term antimicrobial or antibiotic treatment. The primary outcome was quality of life and reduction of symptoms, and the study showed that there was an improved quality of life and reduced symptoms comparable to the antibiotics at 1 month and 3 months after one acute cystitis episode. They, however, showed a higher rate of asymptomatic bacteriuria in the phytotherapy group that suggests that the combination might reduce the symptoms. However, it does not completely eradicate all the bacteria. The next combination includes xyloglycan, which forms a protective barrier on the intestinal mucosa and thereby reduces bacterial adhesion and probably translocation from the gut reservoir. It's combined with glucose, which is comparable to agar, that supports the barrier-forming properties of the xyloglycan, together with hibiscus, which you heard before, and propolis, which exhibits antimicrobial, anti-inflammatory activity. Even so, clinical evidence remains limited. It was tested in a phase 4 double-blind multicenter RCT, including 40 patients, and the combination was used as an adjunct to antibiotics. All patients received antibiotics and the combination or placebo for 5 days, then 5 days alone with antibiotics, and then beginning on day 30 of the study for 15 days per month per 2 months. So this is also a bit like a prevention scheme. In this study, the combination markedly reduced bacteriuria compared to antibiotics with placebo, recurrence, and urinary symptoms like urgency and frequency. And this is underlined by systematic review and meta-analysis, which includes 3 RCTs and in total 178 patients. And the combination seems to be pretty safe, and there's not a high number of adverse events. So the EAU completed a summary of evidence. The level of evidence is quite high, and the recommendations say that we should advise female patients on the possibility of these antibiotic-sparing approaches. Of course, it should always be in informed consent, shared decision-making. And now we will step into the prophylaxis of recurrent UTI. There is again the combination of century and lovage root and rosemary. And for the prophylaxis of recurrent UTI, it was tested in an RCT, including 90 patients. And the herbal combination was tested with antibiotics. So patients received antibiotics for 7 days and then 3 months of the herbal combination. And it reduced recurrence rates compared to the antibiotics alone at 6 months and also at 12 months. And it demonstrated a good safety profile, and it was even tested in pregnancy and seemed to be quite safe. The next combinational therapy that was tested in the prophylaxis of recurrent UTI is the siloglykangelo hibiscus propolis combination. Again, it's the study I explained before that shows some preventional characteristics, and it could show that it's quite effective in preventing recurrences, improving clinical and microbiological outcomes. It also reduces the antibiotic use, and patients were very compliant. Again, here you see a high level of evidence, and the EAU guidelines recommend to advise patients on the use on these combinational therapies to reduce the use of antibiotics. So if the magic potion is able to fight rodents, it might also be able to fight urinary tract infections and antimicrobial resistance.
Thank you very much, Kathrin. That's an excellent overview. I have a question, if you don't mind. A lot of my patients tell me that they've heard cranberry is very useful in terms of UTI prevention, and they specifically ask for my advice with regards to the dose and the formulation. What would you tell them based on the evidence that's out there?
So what I personally always tell them is to try to use the highest dose they can get in combinational treatment. So probably the very sweetened juice you can buy in the supermarket is not as active as higher doses. And I tell them that there is a lot of evidence which is very controversial anyway, but I guess in some patients we see effect and in others we don't.
Kathrin, thank you very much. Thank you very much. Impressive talk. So as you highlighted, so there are 2 indications, the treatment of the acute phase and then the prophylaxis. I would like to ask you, because more and more people or patients are demanding for this phytotherapy. And now my question is about the acute cystitis in this setting. Are there any red flags where you say, please do not use phytotherapy, go directly to an antibiotic, or when is the time you would recommend to switch?
Definitely if there are signs of systemic infection. So these studies are made for patients with acute cystitis and most of the time no risk factors. So especially older patients, it's not tested. I wouldn't recommend it to use it anyway. I usually prescribe it to especially younger patients who try to avoid antibiotics. But if they see that after a certain time frame, let's say 3 days, it doesn't get better anyway, or it gets worse, I recommend to see a doctor or to take antibiotics.
I suppose there's a slightly methodological question as well. So can phytotherapy be responsibly compared in clinical studies?
I would conclude it's only for mild cases, and quite often antibiotics were used in these studies, so as adjunct.
Yeah, I mean, my view on that is I think it is responsible to compare them in a well-regulated research setting where patients will be closely monitored. And obviously drawing on from that, if you can demonstrate high levels of evidence to support their use, then I think that probably is responsible. So our next speaker will continue the theme of non-antibiotic prevention, and this time talk about immunoprophylaxis and also touch on the use of estrogens. And this is José Polo Medina, who is a urologist in Madrid and another member of the EAU infections panel. José is also the ESIU secretary, so I'll hand over to you, José.
Thank you very much. And now we move on to another topic in order to prevent and to treat the recurrent urinary tract infection. And I'm going to talk as the alternative. There are several treatments that we can offer to our patient. For example, the topical estrogen and the immunomodulation. That there are a lot of research in the last year, and this is the topic that I want to review. And regarding the evidence, we review the guideline for the EAU and other association regarding the vaginal estrogen. We had a green flag that is strong recommended with many societies. And regarding the immunoactive agents, has recommended in many societies. First of all, the vaginal estrogen replacement is good evidence about the use of this strategy with 1B evidence. The replacement has to be vaginal estrogen. It has to be in topical. It's not recommended orally because orally does not prevent the recurrence of urinary infection, but vaginally we had a good result in menopausal women. It's clear that we need to recommend estrogen. It's clear that we need to recommend in a chronic management for many years. So maybe the main question is, what is in patient with breast cancer? I try to answer this question with this study published a few years ago. It's important that the study include almost 50,000 patients with a breast cancer, and the analysis of the study, the objective was breast cancer specific mortality, and it's demonstrated in this study there is not a high mortality due to breast cancer in patients with well-controlled breast cancer treated with locally estrogen. I'm not talking about orally, so we can recommend estrogen. We had to do some studies in patients with recurrent infection, but the evidence think that in the future we can recommend oral estrogen in this case, in this patient. As you can see in the previous slide about the phytotherapeutic, about nutraceutical, there are with evidence in almost all the things, but here we have a strong recommendation. We need to offer vaginal estrogen to our patient. Regarding the immunomodulation, the main problem is that there are several types of immunomodulation. We have the Eurobasson for more than 3 decades, that is 18 types of E. coli that the patient take orally during 3 months, and the effective stimulation of the dendritic cell, the phagocytosis, and the macrophages. And we had an evidence, but we are going to review in some second. Another alternative is the formula MB140, that is sublingual during 3 months, and the typical formula is het-inactivated whole bacteria with E. coli, Klebsiella, Proteus bulgaris, and Enterococcus faecalis, including both Enterobacteria and also E. coccus. The mechanism is quite similar with the stimulation of the dendritic cell and also try to stimulate the T cell. And we have another action that is intramuscular or vaginal doses, the sulco urobat, that includes serotype E. coli, Proteus vulgaris, Klebsiella, Morganella, and Enterococcus, that they had better effect with an injection and free with after a booster dose. And the final alternative is the SPET, that is an intramuscular dose using antigens of E. coli. In this occasion, they try to produce specific antibodies. So what is the evidence? I would like to comment two meta-analyses. This one is what published 5 years ago and review all the alternatives. As you can see, at the end, they offer that the immunoprophylaxis can effective in order to prevent urinary tract infection. At EQ review all the articles, not all the articles had a good effect. In many cases, they don't read the statistical significance. So it's necessary to review everything in this. So 2 years ago, Quentin Mack and collaborators published this article that review also the evidence and focus on the different alternatives. First of all, in this table is the study that compared the immunoprophylaxis with antibiotic prophylaxis. The third article with the Urovaxone, there is no statistical difference. And the other studies with the formula MB140 offer that the number of infection with vaccine is less than with the antibiotics. Then the article that are compared with placebo include studies with all the formula, with the Urovaxone, also with the sulco urobat. In many cases, there are not differences. Another problem is that the follow-up was short. And we separate, but I think is the good thing. Between the different compounds, we find with the Urovaxone, in many cases, they find a statistical difference. So I think that is a good alternative in countries where it's available. The only thing that the studies published in many cases are very old, and it's important to update the result. At the other study with the sulco urobat comparing with placebo, it's true that in many cases there are not statistical difference, but it's true when they use a booster, the efficacy is better, but we need also better studies. And this is the reason, because we need to separate or analyze all the formulas in depth and not all together. That in the last year, the guideline had a weak evidence for the auto-vaccine, but it's true, but we need to do more study. That is true that the ON85 and the formula MB140 is the one that we have most evidence. But I need to go deep, but it's true, but there are some studies compared with placebo. This one is a very good one, and try to compare it pacing with 3 months of 4 months with the formula MB140 and demonstrate that the result is quite similar using the formula during 3 months and during 6 months. And it's important the efficacy is maintained through a year. But it's also important that the patient improve all of the infection, and there are many patients with less infection, but in the 50% of the cases, the patient had infection. We had to inform that the patient that probably with the immunoprophylaxis will reduce the number of infection, but probably the patient is going to suffer infection, but less infection. That is a good result. And regarding the side effect, is similar to the placebo. What can you do in males? This is a study also with Dr. Lorenzo Gomez demonstrate that in male immunoprophylaxis is useful and reduce the number of infection in female from 5 infection to less than 0.5 in 1 year, and similar result in male. And another important thing is sometimes they use a booster. And when the patient had new infection, use the booster is a good alternative, because it's important to understand how the immune system works in the bladder. Usually the immunomodulation don't last forever. So it's quite common that 1 year and a half, we need to go for the immunomodulation again. And something that I want to comment is regarding the auto vaccine. For example, in Spain, we only had the auto vaccine available. So last year, with suffer Eva from the ECU group, and in my hospital, we performed a meta-analysis reviewing the formula, the sublingual formula, altogether, all patients with the same formula, and all the study with more than 3,000 patients demonstrate that the incidences of urinary tract infection in 12 months reduced more than 4 times with immunoprophylaxis in studies compared with other antibiotics, and also in the observational studies. And if we go to the auto vaccine, that is that the patient then the urine, the laboratory culture the urine, and the vaccine was made only with the bacteria that are in the urine of the patient. So it's an individualized auto vaccine. We had similar result with the patient with less infection and 12 months follow-up with a probability more than should hold. And also there are many patients with no urinary tract infection in 12 months. But it's important to explain that the patient what this alternative, the immunoprophylaxis, reduce the number of infection, but it's no zero, but they had a probability of the infection recurrent. And finally, we had another alternatives only to mention, for example, the installation of hyaluronic acid, especially with chondroitin sulfate that we can offer to the patient. And finally, I was to recommend the effect of urinary pH. That is important, not only about the survival properties of the enterobacteria, but also for the antibiotics. Most of the antibiotic uses for the treatment of infection had a better response with acid urine, for example, the fosfomycin and the nitrofurantoin. To end, other alternatives about antibiotics. In some cases, we use antibiotics into the bladder. The main problem is only this study reviews in patient with recurring infection, not in neurological patient. What is the patient what we usually use? And I mentioned that this article is by Caroline Ochoa, but is not in antibiotic, but I think she's going to review the main focus of how to treat the patient with a neurogenic bladder, but we usually had urinary tract infection.
Thank you, Jose. Very comprehensive talk. Why do you think that systemic hormone replacement therapy doesn't protect against urinary tract infections, whereas local vaginal estrogen does?
Well, I think there are many things that affect. For example, I mentioned the urine pH. That is one of with the age and with the menopausal, the vaginal pH go more basic. So with the estrogen, we recover more acid pH. That is a way to the patient had less infection. And in some way, the hormonal replacement, the patient had a better epithelia. So maybe protect that the bacteria can adhere to the vagina. That is, I think, is the both reason that we had to offer. And it's important when we recommend estrogen, the patient need to continue with estrogen chronically. It's not only 2 months. We had until they board for the estrogen.
And you talk about chronicity of treatment, which leads me on to my next question. How much information do we have about long-term duration of effect from the vaccines?
Well, the publication is with the longest follow-up is between 12 to 15 months. And it's true that it will review everything together, and not of the study. 80% of the patients are in observational studies, that the comparison is infection before and after of the immunoprophylaxis. About 45-50% of the patient had infection in the first year. But I think the infection is going to appear, and the patient that had in the clinic is very common, maybe that 1/3 of the cases, or 40% of the cases, need another immunoprophylaxis after 1 year because the infection appear again.
Okay, just to finish off, whether these immunoactive agents are safe in patients who are immunocompromised?
Yes, I think they are safe. There is no problem. I usually use in patients with chemotherapy, and in my hospital we had many patients with a kidney transplantation, and we use the immunoprophylaxis. And even in patients with kidney transplantation and in chemotherapy, we recommend 6 months of immunomodulation, not 3 months. We recommend 6 months in order to have better results.
What we're going to do now is move on to our final speaker, who is Miss Carolina Ochoa, who is a urology colleague of mine from the UK working in Bristol. She has a large clinical practice of urinary tract infection treatment, which includes the neuropathic population. She's going to talk again on the same topic of non-antibiotic prevention with specific reference to methenamine hippurate, and then she's also going to talk about recurrent UTIs in patients with neurogenic bladders.
Thank you for the invitation. And I will talk about the methenamine hippurate as a non-antibiotic prophylaxis. So a little bit of mechanism of action and pharmacology before we start with what's in the evidence. So it was discovered ages ago, 1859. What happened with the methenamine is that it's hydrolyzed once it is in acidic urine, and it decomposes to formaldehyde and ammonia, and it's that formaldehyde that disrupts the bacterial proteins. And interestingly, the bacteria cannot gain resistance to formaldehyde. And then the hippuric acid contributes to that acidification of urine, as just Jose mentioned, that is important and specifically important in the methenamine treatment. And it also has some additional antibacterial effect. So pharmacokinetics, the antibacterial activity starts about 30 minutes after the patient has the dose, and over 90% of it is excreted in the urine in the 24 hours after consumption. So the approved dose for adults is 1 gram twice a day. And then we cannot talk about methenamine without mentioning the ALTA trial. So this trial was published by Professor Harding in 2022. And after that trial was published, the most eminent guidelines, including the EAU Guideline, included as a strong recommendation to prevent recurrent urinary tract infections. So what's the ALTA trial? It's a multi-center randomized non-inferiority trial. And they define a non-inferiority margin of 1. So what they did was to compare methenamine to daily low-dose antibiotic. They used nitrofurantoin, trimethoprim, and cefalexin. They found a clear non-inferiority when they compare methenamine with low-dose antibiotics. The adverse events were similar in both groups, in both arms, and this is not surprising. The antibiotic resistance in perineal E. coli was higher in the antibiotic arm. So very important piece of evidence for methenamine. In Pursuit trial, another important trial, slightly different from the previous one. So what they did was to compare methenamine to placebo, and then they did follow-up 6 months, and then under treatment, and then follow-up 6 months, drug-free follow-up. There is less incidence of UTI in the treatment group, so in the patients that were receiving the methenamine compared to the placebo group, and that's the relative reduction of 25%. And then interestingly, they found in the drug-free follow-up how the treatment group incidence of infection was higher. So they hypothesized a possible rebound effect. So there's not enough evidence to say that, but it was an interesting finding, and I think it was worth to mention today. So when we look for evidence, we always look for systematic reviews, and I found that interesting systematic review published in 2024 This includes the ALTER trial. It was 7 studies included in that. And then basically it's consistently support the efficacy and safety across all the various populations, including in all those studies. So what the guidelines mention, that's the level of evidence for the use of methenamine for recurrent urinary tract infections in females, with a strong evidence after the publication of the ALTER trial. So take-home messages for methenamine: we know it's superior to placebo. We know it's non-inferior to antibiotic prophylaxis. Is predominantly studied in female age 50 to 70 years old. There is that hypothesis of that possible rebound effect, but we still need further evidence to say that, and is recommended by the EAU guidelines with a good level of evidence and a strong recommendation.
So we've got 2 questions. They're asking about the long-term safety of methenamine. And the reason they're asking this is because the active metabolite is formaldehyde. That's a classified carcinogen. Whether there's any evidence for long-term safety of methenamine hippurate.
So in the systematic review, I found there is evidence of safety. I don't know specifically in the long term, but you may help with that possibly.
I can. So there's a European Union Scientific Committee safety report specifically looking at methenamine. And unfortunately, the levels of evidence are not high in terms of, what they found. But what they did sort of conclude is that there was no risk of carcinogenicity in the studies that are published so far. I think we have in preparation a study which will come from Norway in due course, which is looking at whether or not there are incidents of cancer in patients who've had long-term methenamine prescription is any higher than the general population. And I think that could probably answer the question once and for all. We have another question about using methenamine in long-term catheter patients, and whether you've got any clinical experience of that, Carolina?
Yeah, more than clinical. I have been looking for evidence in neurogenic patients, and then most of them or many of them will have catheters, and then we don't have any evidence in patients with any sort of urinary tract problem. So known possibly because of the lack of acidification. So there's no good evidence in that. I don't know if you have a different perspective of that.
No, I don't. I agree. There's not any good evidence. But like I say, my clinical experience has been useful in time.
So next talk will be once again non-antibiotic strategies for the prevention of recurrent urinary tract infections in patients with neurogenic lower urinary tract dysfunction. So when we have a neurogenic patient with recurrent urinary tract infections, what we have to remind us is principles of management in this population. So if we have recurrent urinary tract infections, it may indicate any suboptimal management of the patient. So possibly high bladder pressure, either in storage or voiding. It could tell us that there is an incomplete bladder emptying on this patient, or even bladder stones are affecting the patient. So the first is optimize bladder management. We prefer intermittent self-catheterization over indwelling catheters. There is evidence that third study that is there in my reference, that hydrophilic catheters lower the risk of UTI and also reduces the urethral trauma in patients with the spinal cord injury. And then the catheterization technique, very important, the frequency and the equipment, how they do it. So we need to spend time with the patient. If it's not the consultant, it could be a nurse, but we need to provide that to our patients because that's the first step in the management of recurrent urinary tract infections for neurogenic patients. Constipation management, always important in recurrent urinary tract infections, but even more important in this cohort of patients. So daily fluid intake has demonstrated to reduce the risk of infection in general population. There is no specific study for neurogenics, but I think it may apply to neurogenic population as well. And then offering the treatment for that baseline problem. So if we have neurogenic detrusor overactivity, for example, we can offer Botox, and it may reduce the risk of infection or treat the stones. So that's the first thing. So low dose long-term antibiotic may reduce the urinary tract frequency, but as it causes resistance, is not recommended. So let's start with different options. The first one is iodine instillations. There is a good study, it's a cohort study, 119 patients with neurogenic lower urinary tract dysfunction of different etiology. All of them were on self-catheterization for over 12 months. And they were not taking any antibiotic, and what they offered was a iodine instillation daily for 6 months, and they did a follow-up 12 months. So the outcome of it is very good. So it's very promising. Before povidone in blue, and then there is a clear significant reduction in the symptomatic UTIs in those patients, but not only that, but it also reduced the ED attendance, the ED visits in neurogenic patients for UTIs, and also the hospitalization for infections in UTI. So very promising results. As you can see, it was, according to the study, it was well tolerated, and there was no increase in bacterial resistance. But it's a cohort study. This is evidence we have nowadays for iodine in neurogenics. Bladder instillations, so aminoglycosides. There is a good meta-analysis including six studies. There is significant reduction in recurrent urinary tract infections in all the population included. That's not only neurogenics. The incidence rates ratio, as you can see here, is 0.23. So when we have an incidence rate ratio less than 1, the far from the 1 is the better, I will say. So it means 77% reduction in recurrent urinary tract infection risk. When they analyze specifically the neurogenic population, that in this rates ratio was even better. So reduction in recurrent urinary tract infections was about 79%. So gentamicin is has the most consistent evidence, and there is it reduces the recurrence even in multi-drug resistant organisms. All the studies concluded that bladder instillation with aminoglycosides work well for the prevention of recurrent urinary tract infections. This is for the general population. We don't have a forest plot for only neurogenics. So gut replenishment, hyaluronic acid, and chondroitin sulfate. Hyaluronic acid in monotherapy showed efficacy. There's a risk relative, so about 80% relative reduction in recurrent urinary tract infections. When they analyzed the neurogenic subgroup, the risk relative was 0.26, so about 74% relative reductions in recurrent urinary tract infections. And then they analyzed both groups, and they didn't find any significant difference between neurogenics and non-neurogenics. The use of hyaluronic acid and chondroitin sulfate is more imprecise in terms of results. The confidence interval is quite wide, so we don't have good evidence so far for neurogenics. So there we go. So those are the studies included. That's the forest plot for that meta-analysis. The diamond here is quite wide, and this is telling us the heterogeneity across the studies is even higher than the previous one, but still good evidence for the use of hyaluronic acid for prevention in neurogenics. Methenamine hippurate, I just mentioned that the benefit has not been demonstrated in neurogenic urinary tract dysfunction, possibly because of the difficulty of achieving that acidification that we need, possibly due to incomplete bladder emptying. So presently is, according to the guidelines, is not effective in neurogenic population. Immunoprophylaxis, we already discussed about immunoprophylaxis, the good safety profile that José mentioned, does not promote antimicrobial resistance. However, the evidence in neurogenics, as always, remains limited. The predictors of poor response on those of immunoprophylaxis, as just Jose quickly mentioned. So urostomy, that sometimes we have urostomy in our neurogenic patient. Chronic kidney disease, very likely to have, depending on the neurogenic problems, and immunosuppression, less likely to function. So I found for Urovaxon 2 studies. The first one is double-blind crossover trial, 70 paraplegic patients. They could demonstrate significant decrease in bacteriuria. However, they did not demonstrate that significance in the rate of infections. And then the second one I found for Urovaxon was that pilot RCT, only 49 patients because it was a pilot, and they could not demonstrate benefit for the use of Urovaxon in this population, spinal cord injury, MS, and codaquina. But possibly the reason why they did not demonstrate that was because it was a pilot and it was underpowered to do that conclusion. So Euromune, there is a prospective cohort, I think he's from Spain, 71 patients, neurogenic bladder and recurrent urinary tract infections. And then, as Jose just said, that they only have auto-vaccination, and they could demonstrate reduction in hospitalization and ED attendance. And there is a prospective cohort including every sort of patient. Some of them were neurogenics as well, with paraplegia, and some patients on intermittent self-catheterization. And they conclude they demonstrated efficacy regardless whether the patient had paraplegia or were on intermittent self-catheterization. So for additional non-antibiotic options, cranberry products, we have that Cochrane review. It hasn't demonstrated reduction in symptomatic UTIs in neurogenics, small studies, all of them. And then the guidelines do not extend the recommendations for neurogenics for cranberry products. Dimanose and probiotics, I didn't find any specific data for neurogenic lower urinary tract dysfunction. And vaginal estrogens, they could be considered in patients, postmenopausal patients with neurogenic lower urinary tract dysfunction. There is an evidence gap here. However, it restores the microbiome, and it can also improve the mucosal integrity, so probably reduces the microtrauma related to intermittent self-catheterization. So it could be useful, but I don't have the numbers to tell you that today. So take-home messages, the first one and most important, you have to optimize bladder management. It remains the cornerstone in the treatment for recurrent urinary tract infections, especially in neurogenics. Intravesical gentamicin and povidone iodine have the better supported evidence in this order. Consider vaginal estrogens in postmenopausal female is a option. Evidence for methenamine, dimanose, and cranberry is limited. We possibly have to build that up. And there is an evidence gap here. So there's no prophylactic strategy that can be currently recommended without limitation. And the management, as always, should be individualized.
First of all, I would like to thank the former speaker for covering this interesting topic so concise. Very, very well done. Congrats. So I have a few questions. So one general question was about the use of lactobacilli, especially crispatus, in the use vaginally applied in the setting of recurrent UTI. So in my suggestion, this sounds logical, but the data we have, I can only consider it as a nice add-on. So sounds logical to work, but the data are not so good for this approach. And then we have another question, use of iodine installation. To my knowledge, this is more or less an older approach, and the risk with iodine installation in the bladder is you always might hurt or destroy the gag layer and it's just resulting in more complications.
They've talked about contraindications to methenamine.
Yes.
So someone has asked whether CKD level 3 is a contraindication. So methenamine can be used as far down as an EGFR of 10. It's not recommended if the EGFR is 10 or lower. In terms of other contraindications, patients with a history of gout probably shouldn't take methenamine, and patients with a history of uric acid stones. So I think that that probably is the limit of the contraindications to methenamine. I'd like to just go back to Kathrin, if I may, and ask about the sort of directions for future research in terms of phytotherapy. What do you think, what studies really need to be done? And are there any sort of tips in terms of the methodology of those studies when we're looking at phytotherapeutic agents?
I guess as in all preventional studies for urinary tract infections, long-term outcomes would be super interesting. So I think only one of the phytotherapy studies has a follow-up of 1 year. All the others are really only short-term follow-up. And of course, a comparison to antibiotics, only the comparison of the combination with the BNO was compared to fosfomycin. All the others were adjunct to antibiotics. I guess that's also something important, and probably also placebo controlled.
Out of your experience, if you have a female patient with a recurrent UTI problem, and today we have heard many approaches how you can approach or how you can counsel, but which first, which second, which third? Any guidance for us?
Are we talking about neurogenic or non-neurogenic?
Non-neurogenic.
Non-neurogenic. I will start by estrogen initially, if it's postmenopausal, and after that, I would probably go for Dimanos if there is any recommendation for that, and after that, I will go for methenamine, and that would be my and then instillations, bladder instillations.
I have a question for Jose. Do you see any additional advantages for patients using Uromoon if they get patients with cystostomy who's having a recurrent urinary tract infection? So perhaps we could expand that to patients with reconstructed urinary tracts.
Well, I think that in this patient they had a low effect, and Carolina comment that's the study by Bonillo from Valencia that most of the patient has cystostomy or catheterized the bladder, and the problem that the results at this complicated patient is not so well, but usually the patient had less infection, and we can recommend, but it's important to try to other measure. We need to also to know risk factor for infection, and is necessary to correct. For example, there are many patients with constipation. There are many patients with a bladder that don't relax the sphincter and not coordinated micturition, and we need to correct.
Thank you very much. So can I go back to Carolina? There's a lot of questions about the regime, the dosage and the regime for both gentamicin and for iodine, and they're specifically asking as well about dose, regime, and how long you leave these installations in the bladder.
Okay, so I think it changes among hospitals, so it will change depending on. We don't do iodine in Bristol. I don't know if you have experience with that, Chris. What was described in the study, it was not very clear regarding the volumes they used. They did mix the iodine with saline, and then they put that in the bladder, and then was the patient who was doing that at home daily for 6 months, but there's no specific amount mentioned in the paper. And then we use gentamicin instillations for our patients with recurrent urinary tract infections, neurogenics and non-neurogenics. We do use 240 grams of gentamicin diluted in 50 mLs. And then we put it in the bladder, and then we leave it there for, I think it's an hour. And then we ask the patients to pass urine. I don't know if you do something different.
We do. So we use a lower dose of gentamicin. We use 80 milligrams. So I think what we do need going forward is research that's going to clarify the optimum dose, the optimum regime. So I think that will be interesting research going forward. I've got one last question before we finish, just to the panel in general. When should neuropathic bladder patients with UTI be treated? Which is a question you get asked quite a lot, isn't it? So when should we treat? Because often symptoms can't be relied upon.
That's a difficult one. So it's very difficult to say exactly when a patient has a symptomatic UTI if it's neurogenic. So fever is an easy one, isn't it? If they have fever, then we have the answer. But most of them, they will say they have changes in mood, for example, and then they know they have an infection because they feel different, and that's a difficult question to answer. It just, I assume most of them will have infections, but it's a hard one to answer.
Okay, I'll throw the last question up to the panel. How would we treat men with recurrent urinary tract infection? Is there any difference in your strategy? So maybe Kathrin or Jose would like to comment on that. Is there any difference in the strategy you use when you get a male patient with recurrent UTIs?
Yeah, I guess comparable to the neurogenics, we need to check for risk factors first. Is there residual volume? What about the prostate? All that stuff needs to be checked first, and then I guess if that's all fine, I continue comparable to women, except for the estrogen, of course.
Yeah. Anything to add, Jose, to that?
No, I after the same, you have to study the prostate, and in many cases the male had different symptoms, and sometimes it's important to focus the treatment or the symptom that is predominantly in the male.
What I think the overriding message has been when we talk about these groups, neuropathic patients, male urinary tract infections, what strategies might be being developed. I think what we probably need to do, as well as think about new strategies, is look at good quality research studies with well-defined populations. And I think, both neuropathic patients and male UTIs are probably slightly neglected in terms of research. There's so much more out there for women with recurrent UTIs. I'd like to thank my co-chair, Gernot Bonkat, and I would like to thank especially the three excellent presenters, and I hope you've all enjoyed this as much as I have. Thank you very much for listening.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favourite podcast app. Until next time, keep learning and stay inspired.